You're listening to the Physio Matters podcast in association with exerciseprescriber.com, and this is session 70. Welcome back to Physio Matters. I'm Jack Chew and delighted to have got such good feedback from the podcast with Elaine Miller on incontinence and other women's health related issues. It was a long time coming. We've been looking forward to doing that podcast for a long time, and it went down a storm. If you haven't already got to it, it's just a really nice sort of angle for MSK clinicians to upskill themselves and their knowledge and understanding where and when to signpost, as well as giving a quality first contact intervention and advice in MSK when these things crop up in conversations. We need to equip ourselves, and Elaine did a great job of translating that material, and also, of course, a really funny lady, so do check out her other comedy work as well as her physio work. She's brilliant. Big R's is just around the corner. You'll be listening to this, and at a time when the manifesto for reform is out to the conference delegates. So whether you're getting an in-person, getting a few of the last in-person tickets, I think there's a few seats still remaining, or a virtual ticket, then you will have access 2 weeks before the conference to the Manifesto for Reform, which is going to be scrutinised at the conference, as well as also the brilliant clinical content we have. So if you want to get tickets to that, grab the last few at reform.physio/conference. Lots more to come on that, of course, and we really do think it will change the game. That's all been submitted to the designers, and it's a belter. Tens of thousands of you have enjoyed Tom Jesson's podcast on sciatica that we did a couple of months back, and so you'll be delighted to hear that Tom is actually back on the show this month, but as interviewer. His farewell tour of the UK before he goes abroad, as he described in his podcast. He's off to America, and before he did that, he went down to London and interviewed some of his favourites. You've got other specials coming along for that that I'll leave you in suspense for. But this particular one is brilliant because it really visits different corners of the application of pain science education and other psychologically informed therapies, and just talks about some of the challenges and shortcomings and things like that just admit to the difficulties that exist when you apply some of the latest and greatest in ways of science and research to clinical practice. Tom interviews Denneny, who is the chair of the Physiotherapy Pain Association, amongst other roles. And it's an absolutely brilliant interview, really looking forward to it, and we'll soon get to it. One thing I wanted to make sure I touched on this intro is a great thank you to Tom Jesson, who is going abroad, and we hope to stay in touch, and we hope he can still be involved in the show and various other things around it. But it's just been, as we've built the conference sort of rotas and things like that for the tasks and jobs for the conference, that I've realised that he's not going to be there, and increasingly we won't be seeing as much of him, which is very painful for all of us because he's been such an important part of the team. Someone that came to us as a student and was one of our apprentices a few years ago, that's become a brilliant established clinician, and it's been a real joy to see him develop and grow into the role that he has and the influence he has on the profession already at such an early stage in his career, really. So before I choke up and embarrass myself, let's get to his interview with Denneny, and I'll see you at the other side.
I'm Tom Jesson. I'm here at University College London Hospitals, and I'm here with Diarmaid Denneny. Diarmaid, welcome to the podcast.
Thanks, Tom. Thanks for having me.
And I'm looking forward to a conversation today about all things pain management, particularly your interest in psychologically informed practice. But before we get going, are you happy to tell us a bit about yourself?
Yeah, sure. Where to start? So I, as you say, I'm the lead physio for pain at our pain centre here at UCLH. And I've been here for over 12 years now, which is longer than I intended. I started university as a physio in 1991, so it's nearly 30 years. And I did that thing, I guess, that most of us do. You know, went through... Well, actually, I was very lucky. I started in an MDT, a rheumatology service in the northwest of Ireland, and So I cut my teeth in truly MDT working early on, but then I went into musculoskeletal and did my masters in that and was in the MACP. Yeah, and then about 15 years ago, kind of, I guess, realised that maybe there's more to working with people with ongoing pain. So, yeah, that's when I guess really started to get into, working with, well, I was about to say chronic pain because that's the term that the World Health Organization, and others use. But if I do say chronic, I apologise. I also mean long-term, persistent, or ongoing. So whichever of those you prefer to use, I'm happy with.
So it was about 15 years ago you kind of started coming into this world.
Yeah. I started in functional restoration programs. I think there's still a thing some places maybe, but anyway, for back pain. And at that time, I was sitting beside a psychologist, and that was my first real exposure to psychology, clinical psychologists, and kind of got me interested in kind of psychologically informed approaches. And then kind of ended up working in now almost like first contact physio role out in East London. But a lot of that was redirecting referrals from GPs towards pain services rather than perhaps orthopedics or rheumatology or spinal surgery. And at that point I was interested in doing my non-medical prescribing, but I moved here. And initially there was talk about, well, is that relevant? That's quite a medical approach, and here we're biopsychosocial, we're trying to help people to move away from medical. So I kind of put it on the back burner for a few years, and then it just kept coming back, and then I eventually did my non-medical prescribing. And I've been working here ever since, really.
Could you tell us a bit about the setup here? It's a very swish building. It looks very fancy and nice to me. What goes on here?
Yeah, so we actually moved here maybe just over 2 years ago. So the Pain Management Centre is originally part of the National Hospital for Neurology and Neurosurgery. That's where we were sited. But we're right smack bang in the middle of central London, so spaces at a premium, and the hospitals have been expanding. And where we are now is actually the site of the old Middlesex Hospital. So that it was the footprint of the old Middlesex Hospital. It's been, is gentrified the word, but anyway, redeveloped. And as part of the redevelopment, they had to commit a part of it to, public services. And so the hospital agreed to take on this little tiny part, which is now our pain management centre. So we're basically a standalone, if you like, satellite of the National Hospital for Neurology and Neurosurgery. We're what's called a specialised pain service. So NHS England has identified maybe a handful of those in the country. We're one of them, and that basically means we're allowed to perform treatments like neuromodulation, spinal cord stimulation here, which is only allowed to take place at specialised pain centres. We're an MDT, so we have anaesthetist and neurologists are our medical colleagues. We have clinical health psychologists, one counselling psychologist, nurses and physiotherapists. That's the core of our MDT. And we have got a local, if you like, primary care patch, so we take referrals from some of the central London CCGs, Camden, Islington, but we will also accept referrals from other pain centres nationwide. And that's our specialised hat on, that we will take tertiary referrals.
And as well as your work here, you're also chair of the Physiotherapy Pain Association.
I am, yeah. So in January this year I was voted in, so that's been a huge honour. So it's relatively early days, but I'm finding my feet with that. I've been on the committee for the last maybe 2 years. I was the education officer before that. So that's exciting. It's been interesting developing that.
And hopefully we'll come back to talk. Well, we'll definitely come back to talk about that.
Good.
And maybe just to add one more string to your bow, you've done some very interesting research as well, and that was part of a fellowship program.
Yeah. So NIHR, the National Institute for Health Research, offer. Well, mine was called a pre-doctoral fellowship. So for clinicians who are interested in developing their research skills
Mm-hmm.
To go on to then look into the possibility of doing a PhD. So that's the one I did, and I was lucky enough to get that fellowship the year before last, maybe, for the North London Clerk. Don't ask me what the acronym stands for now. I can look it up. We can put it on as a link. And the name has changed since then anyway. But basically that allowed me to work, to step out of my role here and to focus on research for a year. And I had a named supervisor, Professor Steph Taylor at Queen Mary, University of London, who does a lot in public health and primary care. It's really interesting, and just lots of opportunities to develop networks with experienced researchers, and also CPD funding, support to do courses like medical statistics and stuff like that. So it was a hugely useful year, but it also allowed me to have time to write up some papers that had been bubbling in the background for quite a while. Yeah.
One was interesting systematic review of trigger point manual therapy, which we'll maybe come to, but I'd really love to start by talking about your it's work of phenomenology, is that right, on psychologically informed practice?
A phenomenological approach. So we observed some members of the team here. I suppose one of the good things about where we're situated at University College Hospital is that although we're separate to University College London, they're two separate institutions, but we work very closely together, and there's a lot of linking. And Dr. Amanda Williams, some listeners may have heard of. She's a reader in psychology at University College London, and she has one session per week attached to our centre clinically to support us with research. So she, if you like, often draws on our clinical experience for research that's going on at UCL. So there's a team there at the Human Computer Interface Labs, and Dr. Nadia Bianchi, I'm sure I'm saying that wrong, I do apologise. But their team often ask us questions. So as part of the work they're looking at things like developing tech that you can wear, so wearable tech, I guess is the word I'm looking for, and seeing how that could support people with pain. We did a piece of work where we observed physios working with people with pain, and I guess for me it was interesting because there is a lot of the recommendations, and for example Start Back and even the NICE guidelines on low back pain talk about combined psychological and physical approaches, but there hasn't been a lot on what that actually looks like. So we were keen to write up what we have observed with people who have worked in the field for a long time alongside psychologists. So the assumption being that they're using psychologically informed approaches. So we just wanted to observe what we did. And then we mapped that against a competency framework developed at UCL in psychology department there for CBT, and just looked at whether in fact what we were doing, what we observed, did map on, and it did quite nicely actually. So it was interesting work.
And so one of the things I wanted to ask was, what is psychologically informed practice? But almost the very fact that you had to do that study suggests it's not quite clear. But the term's been around for a while, hasn't it?
It has, So this is another thing I'm particularly interested in, is that actually there seems to be a lot of uncertainty or ambiguity about what the term actually means. It was coined in 2011 in that seminal main paper, which was part of a physical therapy special edition on psychologically informed approaches. So they first used that term, and they talked about now I'm going to have to look at the term they used. Psychosocial interventions, I think, was the term they actually used in that paper. But they didn't really describe what, the what of it. They were just giving a more of an overview. And as I started looking into it more, I mentioned Amanda, but Amanda and Vicky Harding, who at the time were based at Input, which is, if you like, a sister hospital to us for pain management services. They have one of the longest running pain management programs, I think, internationally probably, but certainly in Europe, so they had written a paper 25 years ago on physios using psychological approaches.
Oh, really?
So it's not new, but I guess after the physical therapy article and these guidelines that we mentioned, it's become more in the consciousness of clinicians, I guess.
And I think a lot of psychological terms have permeated sort of day-to-day chat between physios, and most people, you hear these phrases like CBT and ACT, and a lot of people can talk about psychosocial factors, doing air quotes.
Yeah.
Is that the kind of thing we're talking about?
Yeah, well, so looking at the literature on this, actually not that many that I found papers it's starting to increase, but not many have used the term psychologically informed. It's my preferred term.
Yeah.
Don't ask me why. But there's a whole load of terms. So as I said, psychosocial is one, biopsychosocial, physiotherapist delivered cognitive behavioural approaches, psychological interventions, psychological approaches, cognitive functional therapy. All of these terms seem to be come under an umbrella of psychologically informed approaches. And then I suppose if you drill down a little bit further, you can start to think about different psychological models which might underpin some of these approaches, which may include CBT or ACT or mindfulness-based approaches.
So is it fair to say that this whole movement is physiotherapy trying to address an obvious need, which is that the body is not just a body, not just a machine, a person is a person and has a mind.
Yeah.
But we don't have a long tradition of dealing with that. So that when we talk about psychologically informed practice, we're trying to draw on a neighbouring discipline of psychology to make our own practice address that fact.
Yeah, I guess, thinking everybody uses the term biopsychosocial model, and maybe thinking about how we address the psychological, and even more recently we're becoming more interested in the social, because that's largely been ignored up until recently, or still is, you might argue. So I guess it's trying to look at, here's an aspect of care that we should be supporting people who are living with pain with. How do we do that? What are the skills we need? What approaches? What's the underpinning theoretical frameworks, if you want to start to go to a whole other level with it. And I suppose interestingly, it's probably worth pointing out, it's not just physiotherapy, but all professions who aren't psychologists. So medics, nurses, occupational therapy. Perhaps occupational therapists are ahead because a lot of their training incorporates psychology and psychological approaches. But in any case, it's all professions who aren't psychologists and working to be able to support people more holistically. I'm not a huge fan of that term, but more biopsychosocially, to use that term. So has that answered your question?
Yeah, it has. And I feel like because it's such a nebulous concept, I think we're kind of honing in on it a little bit. And you said that you felt like, when you did your research, the physiotherapists that you observed were enacting it quite well. Would you be happy to tell us a little bit about what kind of things you observed?
I guess these won't come as huge surprises to people who've been reading the literature, but for example, therapeutic alliance is a large part of it, developing a therapeutic alliance, and the ways that we might do that. From the most basic body language to eye contact to being present, all those things. That alongside, and I'm trying to choose my words carefully, but identifying core beliefs might be one way of putting this. But and the reason I'm choosing my words carefully is dependent on whether you're more CBT aligned or ACT aligned. There are differences here. So it might be identifying the beliefs that somebody has and either bringing awareness to them or dependent on your model, maybe looking at helping people to think about those in a more helpful way. Ultimately, to help them to work towards goals and values. And so goal setting is one of the core competencies in a kind of a psychologically informed or CBT approach, or CCBT, contextualized cognitive behavioral therapy, which kind of again includes ACT and mindfulness-based approaches. And I suppose what's interesting is that on one level, physiotherapy and physiotherapists particularly are trained in many of these core skills, like goal setting, so psychologists use the term behaviour experiments, but we might just say trying out activity or exercise.
Yeah.
And education and information is part of that too. Although it's not just about simply, giving somebody information. It's about checking in with the information you're giving to ensure that the person who is receiving it, one, finds it relevant and useful to them, but two, understands what it is you're actually trying to say, and three, is aware of how to apply that in their situation, in their context. So all of those things, and I suppose on one level it's recognising that physiotherapy has a lot of these skills, and then on another level thinking, well, what are the extra layers that perhaps somebody who's experienced in working in this approach might bring. That's
it, isn't it? Because as you're talking, a lot of these things sound simple. Like I could set a goal now. I could give you a goal, but that's something different to what we're trying to talk about, isn't it? I'm actually quite interested in what your journey was to, I'm going to call you an expert, if that's okay, or you're an expert in this.
Yes.
And what your journey was to becoming someone who's expert in this. Did you go on courses, and how did this happen? I feel uncomfortable with the term expert. I'm a big believer. But I said it. You didn't say it.
I'm a big believer in Kaizen. This idea that we can. It's a Japanese term. It's kind of related to continual improvement.
Okay. Developing experts.
Always improving, because I think we all can. But how did I get? So as I said, I guess I did the more traditional route through MSK and MACP, and you hear this a lot. This idea that even with all of that knowledge and perhaps training, that people still come in and you still struggle because it doesn't quite go how you want, and more often than not, people aren't doing as well as you hope or expect. And so that, and as I say, sitting alongside psychologists, and then where I worked at that time, I was out in Essex, in Basildon and Thurrock at the time. They had a pain management program there, so I was observing the psychologist and the physio, and we had a good pain management physiotherapist. Jan Kuhl was her name, and just observing them got me interested in this approach, and then, as I say, working in more kind of MCATs or triage or those types of roles, again realizing that there's more needed or something was missing, and at that time kind of seeing the role come up here at the Pain Management Centre and just applying I think that might be a good place to develop some of these skills. And I came here, and I kind of still sit on that bridge between biomedical and psychosocial, whatever that is, but I did I suppose I've done lots of I should mention or reference people like coming back to the PPA, topical issues in pain was really for me a game changer in terms of introducing again different ways of looking at and working with people. The NOI group, David Butler in the early days doing his courses, and Lorimer's. So all of that, and then I guess more recently I became quite interested in mindfulness. And I did a year at Oxford in the Mindfulness Centre there, training in mindfulness-based cognitive therapy. So it was like a foundation course, not their MSc. But anyway, it was more to... I was interested in it personally as well as how it could be used professionally. And again, knowing that ACT draws on, mindfulness a lot and things like psychological flexibility and things like that, talk about present moment awareness. But I think there are differences between all of them. So I suppose if I had to talk about where my particular interest is, it's probably veering towards the mindfulness-based approaches. And I have seen lots of interesting, stuff on the Twitter sphere, for example.
Okay.
That, there's a lot of interesting debate. There's a lot of misunderstanding. I'm very wary. I see a lot of people talk about, doing bits of mindfulness or recommending that people should do mindfulness, and I'm wary of all of those things. Mindfulness isn't a panacea. It's not for everybody, and you have to be careful in certain conditions, particularly some psychological states, that it may not be, it might be actually harmful. So like everything, it's caveated, and it's but it's I was interested in that. So I suppose doing lots of different courses, but it's kind of got me interested in this idea that you can perhaps do a weekend course and then suddenly be able to work with some of this material with people who may be coming in quite distressed. Or
how do you feel about
that? So I'm there's a conference in San Diego every year, the San Diego Pain Conference. So I'm doing a talk next year, so on 2020 on my thoughts on this, which is around is it 2-day course enough? I imagine most people appreciate that it isn't, and it's more in the ongoing support. So I feel quite passionate about things like supervision and mentoring in all aspects of life, really, but also for people who may be working with people with long-term conditions, because it's hard for the people living with the long-term conditions, but it can be hard for the clinicians trying to help them as well. So again, I'm going to keep plugging the PPA, but we are interested in this, and we've had feedback from our membership on this, and so we started looking at ways we could support this. And one thing that we're about to run, which I'm very excited about in the autumn, is a online kind of longer program with Professor Frank Keefe from Duke, as they say in the States, Duke University. So he has always been very supportive of physiotherapists and physiotherapists working in pain. And he's a professor at Duke, and he's the editor-in-chief of Pain, the journal. So, but he's been developing or doing training programs at Duke for the staff there, the AHPs there. And we invited him to our conference earlier this year, celebrating 25 years of the PPA. And he, I think he was quite... I think he'd say it's okay for me to say this. He was quite impressed with the reflexivity and the skills of the physios who attended his workshop, and just afterwards at perhaps the dinner or drinks or whatever, as you do, I was picking his brain on how might we support people, how might we deliver something that's perhaps different to a 2-day program, and kind of the seeds of this idea came up. So he's been very supportive, and we're going to, I've got ethics to kind of look at this a bit more objectively, if that's possible, but to get a sense of how it goes, and then to look at how we develop that. Because it's really about supporting people. I'm aware that, I work in a bubble. I sometimes say I'm very lucky, to work in this pain centre, to have, psychologists and anaesthetists and nurse specialists on tap, and I know that lots of people don't have that. And so the hope is that the PPA can develop some kind of support, mentoring, training, but a bit longer term to support people who might be working in MSK a bit more, I say isolated from these types of services, but are meeting these, people with chronic pain. What's the stats? 1 in 3 3, perhaps 1 in 2 if you quote Alan Fayez's paper. He's also a consultant here, by the way. So I do reference it a lot, but it was a very good paper on the incidence in the UK.
Because I think that is we've almost we've skipped quite quickly to the how do we do this topic,
right?
But because I kind of led us there, but that is a huge issue in this, isn't it? Is the theory practice gap, and as someone in my position, and quite early in my career, but I can't quite work out how I would get to your position if I
right,
in terms of being more confident and competent at these things, and it also makes people nervous, doesn't it? Because there's a danger in it's better to not try than to try and get it wrong, I think.
Yeah, and I guess the phrase I hear a lot is, well, I don't want to, I'd be nervous about opening a can of worms. It's often a phrase I hear. So I suppose at a starting point, it's if you're able to, finding perhaps psychology colleagues, clinical psychologists who work in pain, a good starting point. That's, I guess, where I started. I suppose, now, and again, at the PPA conference, there was a real desire to raise awareness that actually there are a lot of physios who have been working alongside, psychologists and have developed these skills, and there's lots of good work coming out. I'm thinking of Zara Hansen's PhD was in kind of CBT and at Oxford, and so nowadays if you can access that sounds terrible. If you do know a psychologist you could speak to, that's great, but if not, then maybe you might have physiotherapy colleagues who have worked in pain for a while. Most regions now have physios who are identified as the person to go to with pain. So, speaking to them, I know you work at the, for example, the Lincolnshire Pain Service and that. So there are more and more pain services cropping up around the country. So sometimes it might even be emailing the lead there and saying, do you know anybody I could talk to or consider setting up supervision with? I think that's a good starting point.
There's a CBT for back pain thing circling around. Have you had a look at that? Because
I have, I might have, actually, funnily enough, I might have put that out originally, and then I saw Sarah Hogg took it up in the US and kind of retweeted it as I think a really good online program as a starting point.
We'll put a link to that in the show notes.
It's free, it's online, and it introduces people to a CBT approach. And I know I keep referring to the different models, but I suppose, understanding that perhaps these approaches have come from, behavioural approaches, which then moved into cognitive behavioural approaches, which have then moved into what are now called third wave approaches, including ACT and mindfulness. So, it's definitely a good starting point.
And you mentioned mindfulness as being perhaps the approach that you're most keen on at the moment. Is that fair?
I think, I always get nervous about these things. I think it's my preferred approach. Yes. That's not saying it's the best approach.
Yeah, absolutely.
But it's my preferred approach because I use it personally as well as professionally.
And what does that... This is always a difficult question to ask you to give like a median example of something, but what does that look like in practice? We're sitting here in a clinic room. Have you been doing some mindfulness today? And
what a good question. Have I been doing some mindfulness today?
How does that
How would it look? So maybe if I give you an example of why I ended up doing the course in Oxford in mindfulness. So I was quite interested in neuroplasticity. I said our centre originally was at the National Hospital for Neurology and Neurosurgery. So we here see a lot of chronic neuropathic or neurological pain conditions. Historically, people who have these types of conditions don't seem to do as well on pain management programs. Interestingly, there's not a lot published on this either. There's some work on diabetic neuropathy, but there isn't a lot on this population and how they don't tend to respond. And I know Tina Live Well Pain, who's
I plugged her website as well.
Good, who's
livewellpain.net.
Livewellpain.net, absolutely great resource, and she's now our patient representative on the PPA executive, another plug, and we're delighted to have her. But her and Keith Meldrum and some people like that have been on talking about neuropathic pain and the differences. And so I was interested in that, and I was interested in ideas around, you know, the nervous system and what might be helpful longer term for people. And if we think about, you know, favourable conditions for neuroplasticity, there's a lot around things like social engagement, like novelty, like focused attention, like repetition. And so that's the language of neuroplasticity. And then if you look at the language of, for example, mindfulness, there's a lot of mapping of the two of those, because a lot of the practices in mindfulness seem to be doing exactly all of those things. It's often about meditating in groups. You can do it individually, but most meditators, if you speak to them, enjoy group meditation. Repetition, doing it regularly. Novelty can be about doing it in different ways, or bringing awareness. They often talk about childlike wonder, or as if approaching for the first time something that you may do all the time, just to try and, you know, increase that novelty and that interest, that curiosity. So all of these things, I guess, are aspects of a mindfulness-based approach. Now you can look at the more formal, like 8-week programs, mindfulness-based cognitive therapy, or mindfulness-based stress reduction programs, which are 8 weeks, 2 hours a week. So I was interested in that and thinking about how we might apply it here to people with neuropathic pain who don't seem to do as well on our general programs. And we did talk about this on a pain concern talk, because my colleague Dr. Claire Daniel, who's a consultant psychologist, and I kind of said, well, maybe we'll see if we can adapt one of our pain programs for this group. Amanda and her and, now I've forgotten her name, a third person, had written a paper on what people who live with neuropathic pain would like in terms of supporting them to self-manage in the long term. And they identified 2 things that I guess stood out from other types of long-term pain conditions. One was around really understanding a bit more about the nervous system. So if you like the psychoeducational component, they wanted a bit more detail, a bit more specifics. And then the second thing was help managing the sudden, severe paroxysms of pain. You know, those really severe, brief episodes of pain, almost gone as quickly as they arise. You know, too quick for medication or for other treatments to be useful or effective. And so I was looking at what they could do there, and we realised that some of the techniques from mindfulness, they don't stop them, but they help people to perhaps get through them with less distress or less after effects. And so we developed this program. It was a pilot. We called it Matrix.
Nice.
Yeah, got lots of questions on that. I'd probably change it now. But anyway, Matrix Reloaded. Yeah. And what we found was by doing this approach, which included, you know, formal meditation practices, along with perhaps a bit more on understanding neuropathic pain, neurological conditions, that people's scores seem to approach were doing better than general programs. Now it's only a small sample, you know, and there's all sorts of caveats, but we still run that program maybe a couple of times a year here. And as it's grown, I guess what we're finding is, you know, we're getting a bit more open to, you know, if people come with an interest in mindfulness approaches, then we offer that something they can consider. So you don't have to have neuropathic pain necessarily, but we offer it for people with neuropathic pain as well. So that was a very long answer, and I'm not sure it actually addressed the question you gave me. But
it's given me like an idea of like a mental image of what that looks like, and I think that's often the problem with these concepts is, well, what does that look like in practice? And that is sounds like quite a specialist setting. So the time is needed, and the certain kind of patient population. But I did notice in your if we go back to the research that you did, where you were kind of filming the physiotherapists, a lot of that is much more informal. It's not, okay, now we do this. It just seems to permeate their practice.
Yeah. And I guess if I use the idea of mindfulness as a way of being rather than a treatment that you deliver, that kind of fits with that. It's that idea of, it is things like being present, being curious, holding things lightly. There's no, as we know, with most long-term conditions. And I'm deliberately using long-term because, pain is one of the long-term conditions, but there's so much overlap between all of them in terms of how people live with them and what they need to do to, engage with life and spark as much joy as they can in their lives. But it's around holding things lightly. There's no black and white. Often there isn't a clear answer. And it's experimenting with things, trying things out, learning from when they go wrong, and rather than stopping.
One of the things I really want to talk about today was psychologically informed practice. But I also have a number of other questions that I want to put to you. The first question, Diarmaid, what is pacing? What's pacing?
What is pacing? Is there a definition of pacing? I don't think there's a clear consensus view on what pacing is. And Pete Moore, I think, has asked about this on Twitter, and I've probably given my interpretation of what it could include. Okay.
Most people think they pace, right? When I started working in a pain service, one of the things that I knew I should probably cover with people was pacing, or at least like raising that topic. And everyone says, "Oh, I do that." So what's the difference between what's going on there?
So pacing, what is going on there? I come back to this idea of no black and white. I think pacing can include a range of strategies or approaches, and really it's going to be about tailoring it to the person and then working out what works best for them. And in that range of strategies, there's all sorts of things like activity cycling. So you might be doing 3 or 4 things during the day, and you might rotate between them. So rotating between different activities could be one strategy that you might use. There may be about a gradual building up is another strategy that some people might use. Incorporating rest into it, maybe an aspect of it that some people might find helpful. I'm trying to think of all of the strategies that we might consider that could come under an umbrella that we would call pacing, and some of those may be useful for some people, and some of them may not be. And it's really about providing the like smorgasbord of strategies and letting somebody decide what they think could be most helpful. And coming back to neuropathic pain, often there's a common feedback from people living with neuropathic pain would be, it doesn't work, it doesn't make any difference to me. And that might be the case for certain aspects of their pain, but for other aspects, pacing could have a role. So it might be around helping somebody to, return to work, or to re-engage with some kind of activity, sport, hobby, whatever it is that they want to do again, that you may use some of these. And you'll see, again, you'll come across preferred ways of explaining it. So sometimes people talk about energy conservation, and they'll talk about things like spoons. There's a spoon theory, which I know is sometimes used. It's not something I personally use, although I know lots of people like it. Because I suppose one of
spoon theory being that you have a set of spoons that you start the day with, and
which
why is it
represent
spoons? I forget why.
I have no idea.
It's just a post on a forum somewhere, wasn't it?
Yeah. And you have a total number of spoons that represent the amount of energy you have. I think. Yeah. I'm not an expert in spoon theory. I should say. But and that you decide how you're choosing to use your energy during the day.
So it's almost like it's almost like the point is that there is a strategy that because it could be so many different things depending on what that person needs.
Yeah, and it's about, I guess that if you think about what it's really speaking to is prioritizing what's important and ensuring that you can manage those things. I suppose, if I'm the clinician in me, which I hate using that term, but I guess one thing I might consider is when that then turns into I use all my energy for certain things and then I can't do the other things that I might also want to do. So, sometimes, again, I guess what I'm really talking about is this idea of tailoring it to the person. But if somebody wants to build up on a certain activity, then spoon theory might not fit very well in that, because they might want to build up, I don't know, their gardening or getting back to work, but they still need to do all the other things in their day. So if you have a very rigid take on it, then you might say, well, I've used all my spoons, I can't do anything else. I'm not saying that, it's never that black and white, but that, just to try and illustrate, you might want to think about, well, how might you approach starting to build up? Because I remember reading Lance McCracken published a paper on pacing where they talk about how it could, if used unhelpfully, could actually contribute to fear avoidance.
Yeah.
Don't ask me the reference. I'm great at knowing I've read papers. I'm very bad at knowing references and names generally. However, for me, I remember reading it at the time, and to me, it resonated in terms of some people I'd worked with. Where I remember once somebody coming in being very strict with how they used a timer and setting a timer, and when I observed it, I thought that doesn't look like it's allowing them to, to do the things that are important for them in their lives. To me, it didn't feel helpful, but that's my interpretation. To the person, they may have thought it was helpful, but I was struck by it. Yeah. And that kind of idea of how pacing could be, if misunderstood, if misused, could end up being unhelpful, and it could feed into avoiding things that we perhaps would like to be able to do again. So, yeah, what is pacing?
Yeah.
It's really nuanced.
Because I've had remarkably little success in talking to people about pacing, that I've just stopped. And I think maybe the reason was that I had too rigid an idea of what it was. That it's kind of taking your task and breaking it down into chunks, so that allows you to do hopefully more over time, so that you don't get into a boom and bust type cycle. Yeah. And that's a very legitimate approach. There's nothing wrong with that.
Yeah.
But I think if I was coming at people and explaining this is what pacing is, how does that work for you? It's probably quite overwhelming for them, and they're going to say, well, so what I should be doing is sort of just floating the idea of having some sort of strategy, and then working it out with them is probably what I'm doing wrong.
I guess it would be around, what's important to them, what are they not doing that they might like to be doing again, and then looking at whether there could be aspects of pacing that could support them with that. And I remember, I go back to perhaps maybe when I started here, I remember we had this very nice handout on pacing, which was very mathematical, and it had a identify and again, you just gave that example, that could be enough for some people in certain situations, that idea of working out and how to build up, and it may fall on its flat on its face for other people trying to use it. It may just not work. But how we might have done it here was this: identify your baseline, how much you can do of certain activities. And then, by identifying the baseline, it's not just about, a snapshot, a one-off. It's about getting a sense over a week or two of roughly how much you can do, given the natural variability of your condition. How you might have better days and worse days. But once you've got an idea of the average, then you might just shave off a little bit and stick at that for a while. So you become consistent, because I suppose a big issue for many people with long-term conditions is this idea of unpredictability and inconsistency. And so one of the things we try to help them with, you mentioned the idea of boom bust. It's about helping people to step out of a boom bust cycle, to help them to realize that just because the pain is doing what the pain does doesn't mean that their activity levels or their ability to function has to mirror the pain. It's perhaps helping people to see that it can be possible to separate what we do from what our pain is doing. And that can be quite a penny drop for some people, even to think that that's possible.
So making that explicit, and people call it like pain contingent and task contingent.
Yeah, function contingent, task. Yeah, absolutely. So pain contingent is where, on a good day we try and do everything we can because we're having a good day. Invariably, people will tell us when they do that they pay for it afterwards, and then they have a bad day or bad days or a bad week or a bad month. And then when the window comes again that they're feeling better, they do the same thing again, and then they pay for it. And over time, the amount they can do in those good spells seems to diminish, get less and less and less. So sometimes, when we're working with someone, we might, we'll draw. People learn in different ways. We all know this. So it might be about drawing little graphs or pictures. I say graph, I don't mean nothing detailed, but to give them exactly, labeling the axes on an Excel spreadsheet. No, but helping them to see a pattern and to consider the possibility of stepping out of that pattern. And just thinking about what other strategies might feed into helping them to break out and to build up what they're doing. But you can even see there it's about listening to the person and what's important to them. It's about giving them some information, the kind of psychoeducational component to it, which is not just about understanding pain, but about them in their context and how they approach things. And maybe even considering that for many people, how we approach things in our lives that have been successful, we will try and apply to how we try and manage our pain, and it doesn't always follow that it's successful when we're managing our pain. So helping people to get unstuck from that may be useful. Not for everyone, but for some.
Things I want to ask you about. Question number 2.
Yeah.
One of your sort of research papers, as I mentioned earlier, was a systematic review of manual trigger point therapy.
Trigger point manual therapy for chronic non-cancer pain. Does manual therapy have much of a role in practice here in the UCL Hospital's pain management service? Very good question. The reason we actually did that systematic review, and it, without wanting to put people off, it was the bane of my life for maybe 3 years. But the reason we did that was, as a specialised centre, we have services for specific conditions. So we're quite a well-known centre for abdominal and pelvic pain conditions, and in that world, for want of a better term, there's a lot of discussion around, like manual therapy, like trigger point releasing type work, internally as well as externally. That's not something I have a skill set in. It's not particularly something I want to develop a skill set in, but nonetheless the question kept coming, is this something we should be doing? And we were very much of the opinion, for back pain, manual therapy for ongoing persistent pain doesn't appear to be particularly helpful or useful. It's not something we do here. Why would it be any different for other conditions? But it just kept coming back to us. So we decided perhaps the best way to do this was to acknowledge that we have biases, and maybe to look at as impartially as we could at the evidence. And I mentioned Amanda Williams is on the PAPAS group for Cochrane, and she said, well, maybe why don't you consider doing a systematic review and maybe even consider doing it through Cochrane. So we approached them and we wrote the protocol, which was published by Cochrane. But I guess what we didn't realise is how much work is involved and how long it takes. And Cochrane were very nice and very helpful, but got to a point of saying, "Come on, guys, we can't publish this. It's just taking you too long." However, we didn't want to waste all the work we had done on this because it is a lot of work. And so we persisted. We continued. We updated our searches, looked at the evidence. So that's where I guess that's where we came up with the idea and why we did this review. We didn't just limit it to abdominal and pelvic pain. We wanted to look at all chronic non-cancer pain, and our findings were, I guess, in keeping with what we suspected. There was some interesting kind of data on function.
Yeah,
but only in the short term.
function, I noticed, yeah.
I mean, there was lots of issues in terms of, all the studies are very small. There was only one, I think, with any long-term follow-up. It's been a while since we've done this now. So, I'm scraping my memory on it, but I had to talk to someone about it recently. So,
and in your experience, is that a stumbling block? So, do patients want or expect that, or does it not come up much?
Well, so good question actually, and I hadn't thought I should say this earlier. So, by the time we get to see somebody, and particularly the physios here, they will have on average seen 5 physios before we meet with them. And now we're bringing up another one of my current bugbears, is this idea of physiotherapy as a treatment rather than as a profession. So the noun verb argument. So we might have to spend some time explaining that here we work differently, the treatments we use are different, that physio isn't a treatment. If somebody comes here relatively acute, and by that I'm being very flexible with the term acute, but we might even be talking within the first 1 to 2 years.
Yeah.
So we see people, who have pain for much longer than that. But and they've never tried that approach. And there may be a sense that it could be beneficial for them, then we might consider. But my colleague Katrine Peterson, who is the physio lead for our abdominal and pelvic pain service, she again, in the spirit of thinking about recognising our own biases in the bubble we work in, has been working with a colleague in the women's health, or is that the right term now? I think it might be pelvic health, because obviously men have pelvic health issues too. So Virginia there, and they've been working together on looking at that group who might be in, again, that grey area where there may be a potential to consider some of these treatments. But for the most part, for the people we see here, they have come to a point of, one, sometimes being wary of having more physiotherapy, because again they think physiotherapy is the treatment, not realising that there are different approaches and different treatments, and that there can be physios who have worked in and have specialised in pain management. So they're often not interested, or have come to a point of accepting manual therapy hasn't worked for me. So it isn't actually that big an issue for us. I probably in my 12 years here, that I can think of a handful of people even in that time who might have said, I really want manual therapy.
The reason I asked was because that was my experience as well, working in the pain service that I do. And I wanted to know if that was consistent unique with yours. So that they're not that interested in. No. And the other thing, I guess, that often astounds me, and it doesn't surprise me actually, I mentioned I did the MACP. I remember coming across a piece of research at that time that said that the more qualified or the more experienced a clinician is, the less time they spend on objective tests and things, the more subjective they do. One of the things here is often you expect people to say, well, I want you to do a physical examination or something. Actually, most people, by the time you finished, are subjective, and it's quite detailed, as you can imagine. We go into lots of aspects of their life, and often by the time you say, do you think an examination would be helpful, they're very much, well, no, you've covered a way more ground than so they don't expect that either. Caveat, your subtext, we're not an acute service, we do, but we sometimes do end up checking red flags and things like that, but for the most part. Okay. Question number 3. You're an independent prescriber.
Yes.
Do opioids have a role in long-term pain management?
Ooh, as in, well, so I could interpret that in a few ways. Do they have a role? They've had a huge role.
Oh, yeah. Okay, sure.
Is it helpful? Look.
Again, I'll frame why I'm asking is because there's a pendulum, isn't there?
Yeah.
And that's why I'm asking.
Yeah. And this is an area I'm very interested in. And again, moving away from, nothing is black and white in life, and neither is opioids and ongoing pain. And what I observe sometimes is a very concrete black and white stance that you might see on, for example, Twitter, where people say, opioids are bad, I'm thinking of, that teacher in South Park, drugs are bad, okay? That kind of a... and I think we have to be very careful that we don't set up that kind of a narrative that, they're all bad.
Yeah.
Because, again, it's not black and white. Are they useful for ongoing pain? The evidence would suggest no. Most of our work here is in helping people to come off opioids. It is, I want to say never, but again, nothing is black and white. It's never about introducing them. But often by the time we see people, they're already on opioids, and it's about helping them to come off them. One of the problems can be that if you've got nothing else that helps you, and someone suggests, I'm going to take away the one thing that you've been using, that's hugely, distressing, anxiety-inducing. So it's not helpful. And I guess for me, I'm interested in that, how physios, for example, might be able to help here, because it's about providing alternative ways of helping people, not necessarily to stop the pain, possibly not even to reduce the pain, but maybe to allow people to do things without making the pain they have worse, and to get on with their lives as best they can. And again, as part of my reading around this and research interests, it's looking at things like, in Australia last year they changed codeine to a prescription-only medication, and the DOH there recommended that that GPs or others should refer this population who were using over-the-counter codeine, they should refer them to physios. And I'm quite interested in this idea of, are we as a profession confident to support that group, which is different from saying, do we have the skill set? I think we have loads of skills to support this population. I can hear in my head now some, again, arguments that, there isn't the evidence yet. That's true, but I think that's something for us to work on and to build to support this group. But it comes back to this idea of confidence, and actually it's something that links into our earlier conversation about psychologically informed approaches. There is a general, for that there's published, lack of confidence for clinicians to be able to deliver these approaches. I suspect there's something similar going on with how we support people with medication, also because it has become such almost a taboo topic, it's and you read all the media reports. I think I saw something even today or yesterday again saying the UK is following the US trends. There are differences. There are subtle differences in our
Why has there been
systems.
an opioid crisis in the States, but not such a one here?
What's the differences? I suppose the main difference would be the because it's a more privatized system, and because the pharma industry has been able to have more of an influence. I need to be careful what I say here. Might need to edit out or put beeps along here.
The Sackler family are listening.
Yeah, exactly. And that they were able to influence more practice, and then when they started to realise that there might be an issue, people, if they couldn't afford it through their healthcare, then had to seek these medications, on, I'm going to say on the street for want of a better word, but and so then that became a huge problem.
We don't have that.
We have so much, a National Health Service free at the point of care. It's very different service delivery. There are, if you look at, so is it Kaiser Permanente or the military? I can't remember what they call it. It's almost as big as the NHS, but it's only for military personnel in the US. And they do support. Yeah, on the wider healthcare platform in the US, they don't. And so people may have been introduced to them, then they're stopped because either their insurance runs out or whatever, and then they go. It's essentially going cold turkey, and then doing what you have to do to try and access your medication, and then having this kind of a black and white approach to, we're just going to stop these medications because they're not helpful. We know there are lots of long-term consequences to these medications, metabolism and kind of endocrine being the main ones. Hyperalgesia being touted as well as something, but so they're possibly not helpful anyway long term. May contribute to the pain increasing. Not so black and white, that one, bit of a slightly greyer area, but they don't seem to help with the pain, I guess, is the main point, and can cause all sorts of other problems. But just being careful, because there's also, you hear talk of things like addiction and drug-seeking behaviour and all these types of terms which are really quite loaded and not particularly helpful and can be quite judgmental.
And patients sense the stigma, don't
they?
Exactly.
Absolutely, and that's not helpful. So it's thinking about what would help these people, what would help them to a point of being able to even consider weaning off some of these medications. Most people that I've talked to, they'll say, if I could, I really would. I really want to come off them, but what else is there for me right now?
What? I'm just thinking of random questions now. I'll edit this a little bit out, but there's a few things just floating in my head, and I'm just seeing how they go, and then maybe we can keep them or not.
Okay.
If we could think of you and I working at in specialist services, and you mentioned that patients have often seen 5 people before they come to you. And we're also lucky that we get quite a lot of time with people, and we work alongside people, colleagues who have specialties that we don't, so on. But as you said, some people don't have those privileges. What can they do to try to stop their patients from ending up with someone like you, if that's the right way to phrase it? When someone has an acute or reasonably new onset of back pain, how should we be trying to kind of account for that possibility?
Well, it's an interesting question, is it? Because there is a lot of really good and helpful kind of advice and information out there now. A lot of approaches around helping people to understand what's going on, understand their condition in their context, and how best to manage that is really helpful. But coming back to that question perhaps about medication and pain, for example, lots of people, one of the reasons that people seem to end up on these medications is after perhaps elective surgeries, so hip replacements, knee replacements, discharged with these medications, but nobody, almost fall between the cracks in terms of who helps them to wean off and come off. And sometimes they're working with physios then, so it'll be spotting those people, just being aware that, how are you getting on with that? Are you finding, even if you're not a prescriber, are you finding that you're increasing them or reducing them? These are perhaps signs that we look out for that tell us if they're, moving in the right direction. Look, it's a lot around how we do our own. I guess there's a CPD question there, isn't there, around how we develop that. But going back to what I said earlier, I think supervision.
This is always a big stumbling block, isn't it? Is how does this happen? And I think it's interesting what you're saying about the Physiotherapy Pain Association potentially getting more courses going to support us with that. Thank you. Plug in a good way. Yes, I guess one of the things we've been interested in is what would help people, what would be supportive, in part why we're developing that Frank Keefe course. I know as the pilot we're offering it just to people who have experience of or work in pain. It was more to start and to test it there. But longer term, might things like that be helpful for people? I guess the way we're going, it's all online platforms. People struggle to get to a course in London or Glasgow or wherever. So what might support them that way? And just feeding back to us on either Twitter or the email or the website, letting us know what would help them. We appreciate all feedback. It's hard to get sometimes, people are busy, but any feedback is useful feedback. And which I guess fits with this idea of,
mentoring, supervision, and depending on where you work, whether you have that in place or not. I'm aware that, maybe somebody who's in their own private practice, that's probably going to cost them, or they're going to have to go out and find it somewhere, versus someone in the hospital should have supervision in place, and they should be supported to identify perhaps somebody in their geographical area who might have a interest and expertise in working with people with pain. But there is still that question. Someone did post, why in this day and age, when we have more healthcare professionals and more awareness, that more people are developing pain? That's a whole bigger question that I'm not sure I have the answer to. But as we said, you don't need to be someone working in a pain centre for years and years and years. Physios, we have a lot of skills that are really useful. But it's some of the... and look, it's been so long since I've worked in MSK. But I do remember when I did, sometimes perhaps being a bit nervous about things like goal setting and stuff like that. I hope it's changed now. I imagine it has. But, some of the basic stuff is really useful.
And do you have, because there's probably the most accessible stuff out there now is, for example, you mentioned the NOI group, Peter O'Sullivan's group, cognitive functional therapy. Yeah,
not compassion focused.
No,
therapy.
Different CFT.
Different one.
And they, from my perspective, seem to be taken over this territory. Do you have good feelings about that? Do you think this is heading in the right direction? Do you have reservations?
I think it's to be applauded, definitely. Raising awareness and a lot of that. It's not even basic information, but that information to around core things like, and I might get this wrong, but I think, for example, making sense of pain, understanding the pain. I think in CFT they talk about exposure with control. To me, that's a different way of saying what we might talk about, which is around behaviour experiments or trying things out. And then kind of more general lifestyle stuff around sleep and managing stress and things. All those things are really, really useful, are really helpful. But I suppose it comes back to this idea of there's a risk that you do a 2-day course or a 3-day course and you think, okay, tick, I've done that. I'll just apply it. Maybe that does work for some people. I don't know, but I guess what I don't see is a lot of longer term follow up or a lot of looking at clinical change, and there's lots of reasons for that. It's such a difficult thing to capture. So one is do people change their clinical behaviours, and how likely are they to from a 2-day program, or even haven't they done some work on delivering a 1-hour lecture and then looking at scores before and after? But what happens 3 weeks later when then you encounter the real difficulty and you're or you're tired, it's Friday evening and your last appointment is a really, really challenging situation. It's often easier to revert back to our behaviours of comfort. So I think it just requires a longer term support net, which is, I'm sounding like a broken record now, aren't I? But things like having that supervision or mentoring in place to support you, the clinician who has maybe done this course. I'm not saying it's bad to do these courses, nor good, and it's kind of the model that we've all grown up in, is that's how we do things. I used to have my CPD folder of all of my certificates, but actually does it make a difference to how I was clinically? I suspect it must have done somehow, but how we capture that. And in part what we want to do at the PPA with this course we're running is see if we can capture some of that change at a longer term with people, with the clinicians. So I think something may need to change there, because of course the other thing is, one, we don't know if the clinicians change their behaviour, and two is I'm not sure we absolutely know that outcomes are better. Which might be slightly controversial, but I'm not aware that we do know that yet. The problem is it's such a difficult thing to measure. There are so many confounding variables, aren't there? But and I'm aware that this is coming from someone who works in this field and uses these things. That do we know that people do better longer term?
Yeah. I think it's fair to say that a lot of the things you're describing have been around for a long time, and sometimes these things are perceived as new or kind of maybe revolutionary.
That was so that was interesting at our conference, the PPA. Some of the feedback was not. I don't think the term frustration is fair, but a sense of we're seeing a lot of these things being promoted as new and different, but actually there have been people using these approaches for a long time. They're not necessarily new, and they may have and
maybe
they cause slightly different things. But But there's a reality that lots of people aren't aware of these things. So it's really good that awareness is being raised about these types of approaches. But I suppose it then becomes interesting to kind of delve into them and understand where they've come from. Where have these ideas come from? It's often not where we expect or realise, I think. And go back a lot further. I mentioned, did I at the beginning, that there was that paper 25 years ago from Input around physios using psychological approaches. Some people might be surprised at that. 25 years, it's not new necessarily, but and I've been going on a lot longer than that. I recently reread Engel's paper, on the biopsychosocial model. That was interesting to read again. To think about what's changed or what hasn't changed or what still needs to change, and just how it's been misinterpreted, I suppose, through the or perhaps the focus of it. There's a lot of talk about it being perhaps reductionist, but when you read the paper I get a different sense from how it was first explained to that identify the three boxes of people's lives, which is an oversimplification and perhaps a misinterpretation or a more simplified kind of translation of what was actually being said.
All right, that's fantastic, Diarmaid. Thanks very much for your time. We've plugged them. Just come up naturally in conversation, didn't it? The PPA a few times.
Yeah.
How can people find out a little bit more about them if they want to?
So, either if you use Twitter, which most people who listen to the Physio
anyone
podcast do, don't they?
Of course,
the handle is at Physiopain Assoc. So, just like PPA. If you search that, it should come up. Or they can email ppapro1994 at gmail.com, or visit our website. So, we've got quite a good website link to the CSB. So just search Physiotherapy Pain Association. I think if you just search PPA, it doesn't come up. So that's that, or my Twitter handle, because I think I've got a link to the website on mine as well. It's just my name.
Just your name.
Diarmaid Denneny,
And we've mentioned quite a lot of really interesting resources today, which we'll put in the show notes. So with that, it just leaves me to say, Diarmaid Denneny, thank you so much for your time. Thank you.
Thank you very much for inviting me. I've enjoyed it.
Huge thanks to Tom and Diarmaid for this brilliant podcast, which I'm sure you'll agree just visits some of the real challenges that we face in clinic when applying some of this material, and explains some of the differences between frontline MSK services and pain services, as well as some of the similarities that, of course, are significant overlaps. So absolutely brilliant, and really enjoyed Tom's farewell tour. We're all benefiting from it, and so whilst I said at the start we're going to miss him greatly, I hope you share your appreciation on social media to him and to Diarmaid, of course. Find Tom at Thomas_Jessen and the Physiotherapy Pain Association at Physiopain Assoc. Final scramble for tickets, reform.physio/conference, in which if you sign up you will also get early access to the Manifesto for Reform, which is out as the conference finishes. So if you don't have a ticket and you want to read this infamous document that's going to change the game, then you can do so on Saturday the 19th from 5 o'clock, of which you can also then become a member of the MSKR think tank, which is very exciting. You've heard it here first, folks. That is the launch of our non-profit, a think tank for MSK Reform called MSK Reform, and you'll be able to join that once the conference is done and the manifesto is out, and you read it and you think, if we enact these policies, Will MSK practice improve? If the answer is yes, you join. If the answer is no, you help us refine it. You help us to persuade you. You help us to improve our messages. So, thank you so much for listening as ever, and we can now go to why you tune in and why you listen to the end, which is for the cheesy sign out.
You're listening to the Physio Matters podcast, discussing physio matters because physio matters.